Your body knows before you do. That is not a metaphor, it is a biological fact. Long before vitamin B12 deficiency reaches the level that produces measurable nerve damage, detectable anemia, or visible cognitive decline, the body has already been sending signals, consistent, physiologically coherent signals that something in the internal environment is beginning to shift. The problem is not that these signals are inaudible, the problem is that we have not been taught to listen to them. We live in a medical culture that treats symptoms as meaningful only when they cross a certain threshold of severity. A little fatigue is not anemia. A little forgetfulness is not dementia. A slight tingling in the fingers is not neuropathy. And technically, in each of those cases, that is correct. But what that threshold-based thinking misses entirely is the period before the threshold, the window in which the body is producing early, specific, coherent signals that a biological system is heading in a dangerous direction. The window in which the course can be changed easily, completely, and without lasting consequence. This video is about that window. About the 8 signals the body produces before B12 deficiency becomes serious, before the nerve damage has begun, before the anemia is clinically significant, before the cognitive decline is measurable on formal testing. These signals are not vague, they are not coincidental. Every one of them has a precise biological mechanism behind it. Every one of them is the body communicating clearly, consistently, specifically that the cellular environment is changing in a way that warrants attention. What changes when you understand these 8 signals is not just awareness, it is the ability to act at the moment when action is most effective. And in the case of B12 deficiency, the difference between acting in this early warning window and acting after the serious stage has been reached is, in many cases, the difference between full recovery and partial recovery. Between a problem solved and a problem managed. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years in the AANEE, what I have come to understand most clearly about preventable disease is this. The body rarely fails without warning. The warnings are there. What is missing, almost universally, is the interpretive framework that would allow a person to recognize them for what they are, rather than explain them away as normal variation, aging, or the inevitable friction of modern life. B12 deficiency is the condition I reach for as the clearest illustration of this point. It moves slowly, it signals early, the signals are specific and recognizable. And the tragedy of every late-stage presentation I see, the patient whose balance has deteriorated to the point of needing a frame, the person whose cognitive decline has been wrongly worked up as early dementia, is that the warning window was there. It passed. Not because it was invisible, but because it was not understood. Before I take you through the 8 warning signs, I want to give you a brief foundation in the biology. Because the signs only become unmistakable when you understand why the body produces them, what is happening at the cellular level that generates each specific signal. Without that foundation, you have a list. With it, you have a picture. I promise to keep creating the most useful and well-grounded videos I can, built on science and clinical experience to help you live longer and prevent the diseases I see every day. All I ask is that you give this fairly new channel a chance and hit the subscribe button. If you get to the end of this video and you did not feel you learned something genuinely valuable, feel free to unsubscribe. No hard feelings whatsoever. But if you give me your time, I will give you everything I have learned for more than a decade in medicine. Please subscribe and let us get into it. To understand what the body is warning you about and why it produces these specific 8 signals rather than some other combination, you need to understand what B12 is doing inside the body before the deficiency becomes serious. Because the warning signs are not the output of a crisis, they are the output of a system beginning to strain. And the biology of that early strain is precise. B12 functions as a coenzyme, a molecule without which certain critical biochemical reactions cannot proceed. It has no substitutes. No other vitamin does what it does. And the reactions it enables are not peripheral. They sit at the intersection of 3 of the most fundamental biological processes the human body performs: producing healthy blood cells, maintaining the insulation around nerve fibers, and running the methylation cycle that governs cellular chemistry from neurotransmitter synthesis to DNA repair. The first system to show the strain of early B12 depletion is the methylation cycle, and this is where the earliest warning signs originate. Methylation is a biochemical process in which methyl groups are transferred between molecules to activate them or change their function. It happens billions of times a day throughout the body, and it governs processes as diverse as mood regulation, inflammation control, sleep, gene expression, and the synthesis of the myelin that insulates nerve fibers. The central B12 dependent step in the methylation cycle is the conversion of homocysteine back to methionine. Methionine is then used to produce S-adenosylmethionine, the body's universal methyl donor, the compound that powers the cycle throughout the day. When B12 begins to fall, not yet to a dangerous level, but below the threshold where the cycle runs at full efficiency, two things happen simultaneously. First, homocysteine begins to accumulate in the blood because the conversion that would remove it is slowing. Second, S-adenosylmethionine supply begins to tighten because the methionine production that feeds it is declining. These two changes happening in parallel are what generate several of the earliest warning signs: the mood changes, the sleep disruption, the subtle cognitive shift, the earliest sensory changes. Not because any single system has failed, but because the biochemical environment in which all of these systems operate has quietly begun to deteriorate. Now, here is what makes this important from a clinical standpoint. Research published in the New England Journal of Medicine established that homocysteine and methylmalonic acid, a second metabolite that rises when B12 is functionally insufficient at the glycochondrial level, become elevated well before serum B12 falls below the threshold most laboratories flag as deficient. In plain terms, the methylation cycle is already under stress, and that stress is already producing measurable downstream effects at a point when the blood test that most doctors order would still report a normal result. The body is warning. The standard test is not listening. The second system under early strain is myelin maintenance. Myelin is not a permanent structure. The sheath that insulates nerve fibers throughout the body must be continuously renewed, a process that draws on the same methylation reactions that serve every other function in the cycle. Specifically, B12 is needed to produce S-adenosylmethionine, which in turn donates methyl groups to the fatty acids that make up myelin. As B12 falls and S-adenosylmethionine becomes less available, myelin maintenance slows before myelin damage becomes apparent. Think of it as the maintenance budget for a building being quietly cut. The building does not collapse immediately, but the gradual deterioration of insulation, plumbing, and structural supports begins at the moment the budget drops, long before anything visibly fails. The earliest peripheral nerve warning signs, the intermittent, mild, easily dismissed sensory changes in the hands and feet, are the biological equivalent of hairline cracks appearing in a building whose maintenance has been underfunded. Structurally, everything still looks intact, but the process that will eventually produce visible damage has already begun. The third system is red blood cell production. In the early warning stage, the bone marrow is still compensating adequately. Full megaloblastic anemia, with significantly reduced hemoglobin and obviously enlarged dysfunctional red cells, has not yet developed, but the efficiency of red blood cell production has begun to decline. The cells produced are beginning to become subtly larger and subtly less functional. Hemoglobin levels may still be within the reference range, but the oxygen delivery capacity of the circulating blood has already begun to decline marginally. The result is a cardiovascular and energetic system operating at 90 to 95% of its previous capacity, enough to feel slightly different, not enough to trigger clinical alarm on routine testing. And underneath all three systems is the absorption mechanism that makes this deficiency so deceptively silent. B12 is the only vitamin in human nutrition that requires a dedicated carrier protein, intrinsic factor, to cross the gut wall into the bloodstream. That protein is produced by parietal cells in the stomach lining. As we age, those cells become less productive. Proton pump inhibitors, prescribed for reflux in millions of people, suppress the gastric acid environment that enables B12 release from food and impairs intrinsic factor function. Metformin, used across the world for type 2 diabetes management, interferes with the allele receptor that handles the final uptake step. Pernicious anemia, an autoimmune condition, destroys the parietal cells entirely. In any of these scenarios, B12 deficiency is not building because of inadequate diet. It is building because the absorption pipeline has been compromised, and the liver reserves that mask it are gradually being drawn down over months and years. The warning signs emerge as those reserves approach their limit. By that point, the deficiency has typically been developing for a very long time. That is what the body is warning you about when it produces the 8 signs I am about to describe. Not crisis, not catastrophe. A carefully maintained system approaching the point where its reserves can no longer compensate and where the downstream consequences of continued depletion will begin to compound. Just really quickly, if this is making sense and you are finding it valuable, please consider subscribing. It genuinely helps more people find this information when they need it. Before I describe each sign, I want to name the pattern that makes them collectively meaningful, because individually, every one of these signs is explainable by something else. That is not a flaw in the list. It is the defining characteristic of a warning sign as opposed to a definitive symptom. A warning sign does not compel investigation on its own. What it does is join a pattern, and the pattern, when you know to look for it, is unmistakable. Several of the following 8 signs appearing together in the same person, building gradually over weeks to months without a clear alternative explanation that accounts for all of them simultaneously, that is the warning the body is sending. Not one sign in isolation, the constellation. The first warning sign is an energy that feels capped, a subtle but real reduction in the upper limit of what the body can sustain before fatigue sets in. Not the severe, unrelenting exhaustion of advanced anemia, a slight lowering of the ceiling. A full day that used to leave energy in reserve now leaves none. A physical task that used to feel easy now requires recovery. Sleep that used to restore fully now restores only partially. The person is not ill in any obvious sense, but their energy envelope has quietly contracted and they have been adapting to its new limit so gradually that they can no longer quite remember what their previous baseline felt like. This is early hematological and mitochondrial strain. Red blood cell efficiency declining at the margins, cellular energy production beginning to be impaired, expressing itself at the level of lived experience before any blood test flags it. It is the body's earliest energetic warning. The second warning sign is a mood that has quietly shifted, not into depression in any dramatic or clinical sense, but into a slightly diminished version of itself. A flatness where there used to be engagement, a patience that has shortened without clear cause, a motivation that requires more deliberate effort to access, an enjoyment of things that has slightly receded. The person often notices this as a change in their subjective experience of daily life without being able to explain it. Those around them may notice it as a subtle withdrawal, a reduced appetite for social engagement, a slight emotional distance that has crept in over months. The mechanism is S-adenosylmethionine depletion, reducing the synthesis rate of serotonin and dopamine, the neurotransmitters that govern mood, motivation, and the experience of reward. These are methylation-dependent pathways. When the methyl supply tightens, they operate at reduced capacity. The mood change is real, neurochemically grounded, and entirely reversible with correction. But because it is gradual and subclinical, it is almost universally attributed to circumstance rather than biochemistry. The third warning sign is a concentration that is slightly less reliable than it used to be, a processing speed that has fractionally slowed, a working memory that requires more effort, a mental sharpness that has a slight softness around the edges. Not confusion, not the significant cognitive impairment of advanced deficiency, the kind of mental change that the person dismisses internally as tiredness or distraction, but which has become a persistent background feature of their thinking rather than an occasional variation. Words that used to come immediately now arrive with a slight delay. The thread of a complex task is slightly harder to hold. Reading requires a little more active effort. This is the earliest cognitive expression of a methylation cycle under strain, the brain's metabolic environment beginning to be less well maintained at the margin before any structural change has occurred, at a stage where full restoration is entirely achievable with the right intervention. The fourth warning sign is intermittent tingling, mild numbness, or an altered sensation, most commonly in the hands, fingers, feet, or toes, that is too brief and too mild to feel worth reporting, but that has been appearing with increasing regularity. Not a pain, not a significant sensory loss. A faint background static in the extremities that comes and goes, often noticeable at rest, often more pronounced at night or after prolonged sitting, often so mild that the person barely registers it before it resolves and they move on. This is the peripheral nervous system at the earliest stage of myelin maintenance stress. Sensory nerve fibers beginning to misfire intermittently as their myelin renewal falls slightly behind. The signal arriving at the brain is slightly distorted. The brain interprets the distortion as sensation where there is none. At this stage, nerve conduction studies may be entirely normal. The warning is functional, not yet structural, but the process that will, without intervention, eventually produce structural nerve damage has already begun. This is the nervous system's earliest warning. It is very quiet. It is very specific. The fifth warning sign is a change in the quality of sleep, specifically a sleep that has become less restorative without any change in duration or obvious cause. The person is sleeping their usual hours. They are not waking dramatically through the night, but they are waking less refreshed than they used to. The sleep feels shallower, less efficient, less complete. Getting up in the morning requires more deliberate effort than it used to. The morning energy that should follow a full night's rest arrives at a lower level than expected. The mechanism here involves B12's role in methylation-dependent melatonin synthesis, the process by which the pineal gland converts serotonin to melatonin to regulate the sleep-wake cycle. When methylation slows and serotonin synthesis is impaired, melatonin production is also subtly reduced. The result is a sleep architecture that has become fractionally less deep and less restorative, not because of any sleep disorder, not because of lifestyle factors, but because the biochemical process that maintains the sleep cycle is operating below its optimal capacity. The sixth warning sign is a subtle change in skin, hair, or nails, specifically a complexion that has become slightly more pale or slightly more grey than it used to be, hair that has become a little more brittle or is shedding marginally more than usual, or nails that seem to be growing more slowly and have lost some of their previous resilience. These changes reflect B12's role in the rapid cell turnover that maintains all fast-renewing tissues. Skin cells, hair follicle cells, and nail matrix cells divide continuously, and that division requires the DNA synthesis that B12 supports. When B12 falls, cell turnover in these tissues slows imperceptibly at first. The changes are subtle enough to be attributed to stress, season, hormonal variation, or simply the normal process of getting older. But in the context of the other warning signs in this list, they are part of a coherent pattern of a body whose cellular renewal has begun to operate at reduced capacity. They are the visible surface signal of the same deficiency process that is happening invisibly in the nervous system and blood. The seventh warning sign is a mild oral sensitivity, a tongue that has become slightly more tender than usual, a mild burning sensation that appears after eating certain foods, a subtle awareness of the mouth's interior that was not previously present, or a mild soreness at the corners of the lips that comes and goes without obvious cause. The mechanism is the same as for skin and hair, B12's role in the rapid renewal of mucous membranes throughout the body. The tongue and oral mucosa are among the fastest renewing tissues in the body, and they are sensitive to early reductions in the B12-dependent cell turnover process. The changes at this warning stage are far milder than the dramatic glossitis, the smooth, painfully inflamed tongue of advanced deficiency. But they are real, they are specific, and in the context of the pattern I am describing, they are worth noting. The eighth warning sign is a mild awareness of the heartbeat or breath during routine physical activity, not palpitations in the dramatic sense, not breathlessness that stops the person in their tracks, but a subtle noticeability, climbing a flight of stairs and registering the heartbeat in a way that would not have happened previously, walking briskly and noticing the breath requiring slightly more conscious management than it used to. These are the earliest cardiovascular expressions of preanemia, the blood's oxygen-carrying efficiency beginning to decline at the margin, just enough that the heart and lungs have to work fractionally harder during mild exertion to maintain adequate tissue oxygenation. Nothing abnormal would appear on any cardiac or respiratory investigation at this stage, but the body is already compensating, and in that compensation, it is signaling that the oxygen delivery system is beginning to be stretched. I want to begin this section with a point that I think is worth stating clearly. The reason to act on these warning signs is not fear, it is opportunity. Early B12 deficiency, investigated and treated appropriately, resolves completely in the vast majority of cases. The fatigue lifts, the mood stabilizes, the concentration returns, the tingling stops, the sleep becomes restorative again. This is not a condition you manage at this stage, it is a condition you correct, and the practical steps to do that are not complicated. The first step is getting the right investigation and understanding why routine testing alone is insufficient at this stage. Ask your doctor for serum B12, serum methylmalonic acid, and serum homocysteine together. Serum B12 alone will often appear normal or low normal at the warning stage, even when the functional markers are already elevated. Research published in the American Journal of Clinical Nutrition has confirmed that a substantial proportion of people with serum B12 in the low normal range, below 400 picograms per milliliter, already have elevated methylmalonic acid and homocysteine, indicating that tissue-level B12 function is already impaired. The functional markers catch the warning stage. The serum B12 alone frequently does not. Bring this to your doctor as a specific and evidence-based request. The second step is assessing your risk profile, because understanding why you might be deficient is as important as confirming that you are. Are you over 50? Intrinsic factor production declines with age, and B12 deficiency becomes substantially more common after this point, regardless of dietary habits. Are you on a proton pump inhibitor for reflux? Long-term use meaningfully impairs B12 absorption, and this is rarely monitored proactively. Are you taking metformin? Research published in the British Medical Journal has documented B12 depletion in a significant proportion of long-term metformin users, and this is almost never flagged at the time of prescribing. Are you following a plant-based diet without consistent B12 supplementation? Dietary B12 exists only in animal products, and without supplementation, depletion is not a question of if, but when. Any one of these factors substantially raises the probability that the warning signs in this video have a B12 driver. The third step is understanding your treatment options in proportion to your situation. For early deficiency with intact absorption and no significant underlying cause, high-dose oral B12 supplementation, typically 1000 micrograms daily, is effective. At that dose, passive absorption delivers enough B12 to correct early deficiency in most people within weeks to months. I am not suggesting anyone dismiss the importance of identifying the cause. Understanding why the deficiency developed is essential for deciding whether ongoing supplementation is sufficient or whether something more needs to be addressed. If the cause is impaired intrinsic factor production from pernicious anemia, from age-related gastric atrophy, or from long-term PPI use, intramuscular B12 injections that bypass the gut entirely may be the more reliable route. Your doctor will guide you on which approach is appropriate. What matters most at the warning stage is that the conversation happens now, not after the warning has been ignored long enough to become something more serious. The fourth step is dietary optimization as a supporting layer. The richest dietary sources of B12 are liver and kidney, organ meats that carry B12 concentrations far higher than any other food source. Oily fish, beef, eggs, and dairy provide meaningful amounts. For plant-based eaters, fortified foods contribute some B12, but are generally insufficient to correct even mild deficiency without supplementation. Alongside them, I want to be direct about the hierarchy here. If absorption is intact and the deficiency is early, dietary richness in B12 sources is a meaningful contribution to the recovery strategy. If absorption is impaired, diet alone will not correct the deficiency, regardless of how B12 rich it is. The food contains what the body needs. The mechanism for extracting it is compromised. Addressing the mechanism is the priority. The fifth step is follow-up, structured and symptom-tracked. At 8 to 12 weeks after beginning any intervention, review your symptoms honestly and specifically. Has the energy ceiling lifted? Is concentration clearer? Is the mood more engaged? Has the tingling reduced in frequency or intensity? Is sleep more restorative? Is the oral sensitivity settling? These subjective markers, tracked consistently and honestly, are as important as the blood result in assessing whether the intervention is working. At 3 months, retest B12, methylmalonic acid, and homocysteine to confirm the functional markers are normalizing. Early deficiency treated appropriately should show clear, measurable improvement within this time frame. There is a phrase I've heard used in medicine that I find both useful and occasionally misleading: watchful waiting. In the right context, for conditions that may resolve spontaneously or where treatment risks outweigh benefits, watchful waiting is an appropriate and considered clinical strategy. For early B12 deficiency, it is not. The deficiency does not spontaneously resolve. The liver reserves continue to draw down. The methylation cycle continues to strain. The myelin maintenance budget continues to be cut. Watchful waiting in this context is not a clinical strategy. It is allowing a correctable problem to become a more serious one while observing it happen. What the research says about this is unambiguous. A study published in Practical Neurology examining neurological outcomes in B12 deficient patients found that the single most predictive factor for complete recovery was not the severity of deficiency at the time of treatment, it was the duration between symptom onset and treatment initiation. Less than 6 months, near complete recovery in the majority. More than 12 months, substantially reduced recovery, with a meaningful proportion retaining permanent neurological deficit. The biological window is real, it is defined, and it is measured in months, not years. I want to tell you about a patient I saw in clinic, not in the emergency department, but in a follow-up setting, who had come to me after recognizing herself in a video very much like this one. She was 58. She had been on a proton pump inhibitor for 4 years for reflux. Her GP had told her at her last annual review that her routine bloods were normal. She had been experiencing what she described as a gradual, creeping reduction in her usual self for about 18 months, tiredness that felt deeper than before, a thinking that felt slightly slower, a mood that was flatter, fingers that tingled occasionally at night. She had attributed all of it to the menopause transition and the demands of caring for an elderly parent. When we tested her B12, methylmalonic acid, and homocysteine, her serum B12 was 231, technically within range. Her methylmalonic acid was elevated. Her homocysteine was elevated. She was in the warning window. We started intramuscular B12 injections. At 3 months, she described the experience as, and I am paraphrasing, feeling as if the world had come back into slightly sharper focus. Energy, mood, concentration, sleep, all meaningfully improved. The tingling had resolved entirely. She had not reached the stage of serious deficiency. The warning had been heard in time. That outcome is what the warning stage is for. Not to frighten, to enable. The body produces these 8 signals because the biology has enough integrity remaining to send them clearly at a point when acting on them is straightforward and the outcome is reliably good. The question is whether the signals are recognized for what they are. A slight reduction in energy, a mood that has flattened quietly, a concentration that requires a little more effort, a tingling too brief to mention, a sleep that does not quite restore, a skin and hair that seem slightly less vital, a tongue a little more sensitive, a heartbeat a little more noticeable on the stairs. None of these compels action on its own. All of them together in the same person, building over the same period of time that is not background noise, that is a warning. And warnings, unlike crises, leave room to act before the consequences arrive. If you found this useful, please subscribe to the channel to help me reach more people like you.